All right, let me get this music off. I'm doing a new platform here because we had some technical issues. So welcome everyone. This is our third live, and hopefully it goes better than the other one that we had, and that we don't have a lot of technical issues using the StreamYard. Okay, so drop your questions in the chat. I'm going to be answering them in the order they're received, and then super chats will get priority, as well as channel members. That's one of the features of being a channel member and supporting us, is that you get priority answers to your comments and questions in live chats. All right, so I think we have some questions now, so we can go ahead and see what they are. Here we go. All right. So Ron Harris, I think you said you're from Tennessee. So hi, Ron from Tennessee. I also see we have someone from India. So thank you for tuning in. I know it's late over there. So Ron, how can I get off Seroquel? Do people ever get off of it? That's a very good question. Seroquel is an antipsychotic medication, also can be given as a mood stabilizer. And it depends the question of, do people ever get off of it? Yes, people do. But depending on what you're prescribed, like why you're prescribed Seroquel, will determine on whether or not you can get off it and stay off of it. For instance, bipolar mania and things like schizophrenia may not if you come off of it, those symptoms, will return most likely, and then you're going to need another different, treatment option. Now, to get off of it, you're going to have to taper off of it slowly. The lowest dose you can get in pill form is going to be 25 milligrams. Then, depending on if you're on extended release versus immediate release, would depend on how you would go about your taper schedule. But you would want to reduce by the lowest dose every, I would say, 4 to 6 weeks. So it's a very slow taper. However, some patients can't even tolerate that. That may be too big of a jump, especially if you go down to the lowest. Like if you're down to 50 milligrams and then you try to cut by half. That can be problematic for some people. And in that case, you would need to find a compounding pharmacy in your area, or work with a provider who has connections to different compounding pharmacies to have the medication compounded in liquid form, and then do like 10% cuts every 4 to 6 weeks. There is also going to be a deprescribing guide that's going to be coming very soon. Actually, I'm supposed to be getting mine either today or tomorrow, so I'm excited. It's called the Maudsley Deprescribing Guide, and it's going to have deprescribing guidance for a lot of the psychotropic medications in there. So I will be doing a video on deprescribing and highlighting the book, so that way you guys can get a better idea of that. But this is a very good question because it's not just Seroquel that people have trouble coming off of. Oftentimes it's the antidepressants and the benzodiazepines as well. And that's what the book is going to be focusing on. Okay, so next question. Do we have another question? Next comment or question? Okay. So I'm Kathy Tarleton. Hi, Kathy. I think you may have called me and left a message. Okay. Anyhow, I'm glad you're here. Okay. My husband is suffering from steroid-induced psychosis. He got 6 months ago, and no SSR or antipsychotics seem to help him. Okay. Have you ever treated a patient with this condition? And if so, with what meds? Yeah. Steroid-induced psychosis is definitely something that most of the time requires hospitalization, especially if it's severe psychosis. I have seen patients with this. I haven't treated them personally because in my practice, I work in outpatient, but when I worked inpatient as a nurse, as a registered nurse, I seen this. So I wasn't prescribing the medications. And sometimes, we'd give them an antipsychotic medication orally and it would work, something like olanzapine. Other times it wouldn't, and they would get aggressive and, of course, not be themselves. And we'd have to do injections. And oftentimes those injections included things like Haldol, Ativan, and Benadryl. And then we would do that until it cleared. Now, if this is 6 months ago and still having it, I'm guessing that it's probably not acute where, he's attacking people or being that aggressive in the psychosis. But definitely the other thing to remember here is that with medication-induced psychosis, whether it's steroids or other medications, because this can happen with other medications, I've seen it with others as well, and even like marijuana. Something is happening in the brain. We're not exactly sure, but there seems to be some damage going on there. And that takes a lot of time to heal. So focusing on, what I do is holistic. So herbals, maybe some turmeric, some ginger, if you can tolerate that, to get inflammation down. It's not going to help the psychosis, but it can help maybe some of the underlying issues that are going on. And hopefully the doctors have done some blood work to see if he has high inflammatory markers. Also looking at his MTHFR or the homocysteine marker. If that's really elevated, he may actually be needing nutrients like methylfolate, B12, and also looking at his vitamin D. Those would be like the basics. And then ruling out anything else, thyroid function or dysfunction, and different anemias, omega-3 deficiencies as well. So kind of looking at what could be the possible root causes there is the path I would take in this type of situation, and then help provide him with the nutrients that he needs, make sure that he's eating a well-rounded healthy diet. And then you said none of the antipsychotics or SSRIs seem to help. Sometimes it requires combinations of medications to help, like maybe an antipsychotic and a mood stabilizer. Lithium can be very helpful in these situations. So maybe something like lithium and olanzapine, and as a temporary thing, and until he gets better, and then is fine, and then you can start the slow taper process off, deprescribe, and see if any of the symptoms reemerge. But a lot of this is going to take time to heal the injury that's occurred from the steroids. Okay, next question, if we have one. What is the best treatment in medicine for hypomania? Well, I hate to say best treatment, right? Because it's going to depend on the person and what you can tolerate, right? So for hypomania, oftentimes mood stabilizers are first line treatment. I like to use lamotrigine as a first line treatment when I'm looking at a hypomania or bipolar 2. Um, if the person has tried it and it hasn't worked, perhaps lithium, again, going to mood stabilizers. Others would be like Depakote. And then the rest don't really have a lot of evidence base for them, but medications like Tegretol, carbamazepine, and oxcarbamazepine could also be used. And with hypomania, you have to be very careful with the SSRIs or the antidepressants. Because you can actually push someone from hypomania to mania. So that's something you have to be very cautious with. If the mood stabilizers aren't effective, then you would go to like the antipsychotics, which can be used as mood stabilizers with bipolar in those spectrums. So the newer ones like Latuda and Vraylar are going to have a less of an impact, metabolically speaking, because they don't have the weight gain component as a side effect. So Latuda right now is now generic. It's not branded anymore, so that's good. You can get that as a generic now. But Vraylar is still branded, so that would require some insurance, steps that you would have to take to get covered. Use a savings card, etc. To help with that. Then you have the older antipsychotics like Seroquel, Olanzapine, Abilify, which can be very helpful, but do come with a lot of side effects. And not saying that Latuda and Vraylar don't come with side effects, because they do. It's just not the weight gain piece, which is very huge, especially with Seroquel and Zyprexa, though those two medications are very useful and very helpful in manic situations. But hypomania, that might be a little bit much to go to those quote unquote big guns. So start with the mood stabilizers, see what you can tolerate there, and then go from there. Thanks for your question, Mohammed. Do we have another question? Elias. Hello, Elias. Sondengrad. Do you know when Auvelity will be available in Europe? I do not know when it will be available. The thing about Europe, which I think is actually good, that other countries actually have a more rigorous approval for their medications, which is why a lot of things that we get here in the US, you don't get in Europe. And I think that that's a good thing, because a lot of medications we find out later on, after years of people using them and being on them, that they're causing actually some damage, and sometimes more damage than good. And that's why I say you always have to weigh the risk versus benefit with using psychotropic medications, including the antidepressants like Auvelity. It's fairly new, showing a lot of promise, but we don't have any real long-term, someone taking it for years, 4 or 5 years yet. So we don't know those long-term effects. So just something to consider there. But I don't know when it'll be available, but just know that Europe is doing more rigorous studies and research to make sure it's safe for you. Okay, next question. How hard is it to get off 2.5 milligrams of olanzapine? Well, antipsychotics, in my practice, from what I see, I haven't had many patients have trouble coming off of them when we cross taper or come down from them. However, I hear that they can be difficult to come off of for some. From what I'm hearing, I don't have all of the data. It seems to be very low percentage of patients would have a hard time coming off of antipsychotics. However, because they are hitting serotonin, they can. So I can't really say how hard it's going to be for most people. I can get them off 2.5 milligrams fairly easily. And how I would do that is every other day dosing for some time and then stop. So depending on how long you've been on it, at least doing that for a month. If you've been on it for years, probably doing that for a few months and then monitoring your symptoms, seeing how you're doing and then coming off. And again, it all depends on what you were put on it for. Should you be coming off of it, or should we be switching you to something else? And that's a whole different process. That's cross tapering, which looks a lot different than deprescribing and just tapering. If you do have trouble at 2.5, because this is the lowest dose, you can't go any lower with olanzapine. You can do the liquid formulation with a compounding pharmacy and, do like 10% reductions, 5 to 10%, depending on how sensitive you are with the medication. Okay, next question. My walkies. How to manage manic side effects of bupropion for ADHD. Wow. Yeah. So decrease the dose. Talk to your provider. Okay. All of this is under, the disclaimer of talk to your provider, right? Because I'm not your provider. But if you're having, manic side effects, I'm questioning why are you having them? Perhaps you're on too high of a dose, and perhaps um that you're getting too much dopamine in that area of the brain, and screening for possibility of underlying comorbidity of bipolar that may have looked like ADHD, and then you got put on a medication like bupropion and now you're having manic symptoms. So with side effects of that, a lot of conventional providers will actually add a medication like an antipsychotic. And that's unfortunate, because that's an adverse effect. And so, again, you'd want to make sure that you're looking at the underlying, making sure there's no underlying bipolar or schizophrenia or any type of psychosis going on, but get the patient off of the bupropion, lowering the dosage to see if that mania subsides, and then kind of regroup and determine whether or not this was actually ADHD, whether it was bipolar, whether it was something else. And if it was an adverse effect to, bupropion, trying something else to treat and manage the ADHD if it turns out that it was a true ADHD. That's a good question. Next one. Elias again. Good. How do Lyrica and lamotrigine work for anxiety? Do they increase neuroplasticity? Does high glutamate cause anxiety? Okay, several questions here. So Lyrica and lamotrigine can work for anxiety. Lyrica is a controlled. It is working in the GABA receptors, and then your mu receptors, which is the opioid receptors for pain, right? That's what it's given for. Though it's used off label for anxiety, that's not its indication. And so I don't use it for anxiety, though it can, and that's the mechanism of action of how it can work. It's by engaging the GABA receptors, and yes, turning down glutamate. So yes, high glutamate can cause anxiety. Lamotrigine works a little differently, works in the sodium ion channels, but as a downstream effect, that actually can turn down glutamate and increase some GABA. So it is oftentimes used off-label for anxiety, but most of the time for depression mixed with anxiety, lamotrigine can be used for. Lamotrigine is more of a mood stabilizer in that regards. Do they increase neuroplasticity? That's a good question, because there is some research stating that SSRIs, which these medications are not categorized under, are actually showing that those medications can actually help with increasing neuroplasticity, decreasing brain inflammation. I haven't seen anything on other medications like mood stabilizers and the pain medications doing having to do with neuroplasticity, but it is a possibility that they can increase neuroplasticity. Thank you for that question, Elias. All right, unknown aspirant. Hello, doc. I'm a psych nurse practitioner, but that's okay. I know a lot of people and even some of my patients call me doc, but that's okay. Just wanted to make the differentiation there so I don't ever get accused of posing myself as a doctor. All right, anyway, I'm from India. I'm 17 years old. I'm diagnosed as a depression patient with brain tumor. What do I do? That's unfortunate. I'm sorry to hear that. With a brain tumor, definitely see a neurologist. I'm sure you're probably under the care of a neurologist. I imagine, depending, with the brain tumor, the placement of that brain tumor, maybe it's somewhere in the limbic area, the hypothalamus, or even prefrontal cortex, can be affecting, your mood. And so, I'm not really sure how you would go about with treating the depression itself. I'm guessing they would probably use conventional methods such as SSRIs to help with that brain inflammation and neuroplasticity, but not really sure how much that is going to be effective because there's a tumor there. So if it's benign or not benign, is it something that they can remove or not remove? Those are all questions to be thinking about and to ask a neurologist. And maybe there's ways that they can decrease the brain tumor in order to help give you some relief with your mood symptoms as well. But that's certainly not in my wheelhouse to treat. I haven't treated someone with a brain tumor, so I really am just throwing out like what I think that they may try, and maybe even anti-inflammatories to reduce brain inflammation. But look at holistic ways, omega 3s, diet, anti-inflammatory diet, things to help improve mood and focus that you can take naturally, green tea and things of that nature, blueberries, blackberries, things like that can also just be helpful. Okay. Okay, we have a super chat, our first super chat for the day. Thank you, Nerd Mama. And we'll do a little celebration. Thank you. All right. So, how can ashwagandha be used with antidepressants? Well, ashwagandha is an adaptogen. Okay, so what an adaptogen is, it's an herb that is used to help the adrenal glands adapt to stress. So it can help oftentimes reduce stress. The thing about ashwagandha is that I find is that not everybody can tolerate it well, and that it has a lot of patients, at least the patients I manage, because they're coming off of medications. A lot of my patients are coming off benzos or antidepressants, so their nervous system is already very sensitive. They can't tolerate ashwagandha, and actually has a paradoxical effect, meaning it causes more agitation, irritability, restlessness, those types of symptoms. However, if that's not the case with you and you're tolerating it well, it can be used with antidepressants. You just want to do a drug interaction check just to make sure. Off the top of my head, I can't think of any drug interactions with ashwagandha with antidepressants, but just do a drug interaction checker. I'll put a link, or have Raul is in the background helping me, so have him put up a link for drug interaction checker so that you can go in and check, the ashwagandha with whatever antidepressant you're talking about to make sure it's not inhibiting the antidepressant. But you would just take them if there's no drug interaction together, to get that decrease of mostly the anxiety and the stress response, if it's something that is helping you. So not so much that it's going to help depression, but perhaps you have a depression mixed with anxiety. That's how you could leverage that herb if it is something that is working for you. Okay. Laura. Hi, Laura Riccardi. What are the best antipsychotics to use in elderly? Good question. All of the antipsychotics come with a black box warning for the elderly population that they have an increased risk of cardiovascular incidents and stroke. And so you have to be very careful with this. This is particularly seen in the patients with Alzheimer's and dementia, because those are the patients that oftentimes get put on these antipsychotics. So you have to be very careful there. Now, the only antipsychotic that is FDA approved for agitation, irritability in Alzheimer's dementia is Rexulti, which is brexpiprazole. Now, just because it's FDA approved doesn't mean that it doesn't have that risk. It still has the risk. It's just that they did the studies and showed that that Rexulti does treat that agitation, irritability, those types of symptoms that are often seen in Alzheimer's dementia versus placebo, and got approved through FDA trials. And they also still though have that black box warning of can increase cardiovascular accidents. So overall, what you want to do is weigh out those risks versus the benefits. What are you trying to treat with an antipsychotic? And is it worth it? And like, so thinking quality of life, right? How old are you? Do you have 20 more years, or is it only maybe 5 or less? Or we really don't know, right? But I'm saying, as you get older, those are things that you start thinking about, and then gauge, like, if this will help improve my quality of life, is it worth this risk of a cerebral vascular accident, which is stroke, or cardiac arrest, which is heart attack, which can occur, rare but can occur. So just know that, and look at all my different videos that I do. I have some research articles in those different ones on the black box warning and things of that nature. So look at that, so that you can see and weigh out, the risk versus benefit. Lots of research out there on it, and percentages to look up and to think about. Okay. Nerdbama, hello again. Always good seeing you. You're still on Effexor 187.5, but still deal with physical symptoms of anxiety that trigger rumination. Would going up help, or add something, or just change it altogether? Well, symptoms of anxiety that trigger rumination. So the higher up you go with Effexor, you're actually going to start getting more of that norepinephrine, the SNRI piece of Effexor versus serotonin. So right now you're getting quite a bit more serotonin than norepinephrine. As you get up above 225 or 250, I believe, is when you start getting more of the norepinephrine. So that may not actually help. It may actually maybe even make anxiety worse because of the more norepinephrine. And Effexor isn't my favorite antidepressant. As you know, I've talked to you about this before in these lives, just because it has the high risk of withdrawal, effects of coming off. And even when you're trying to switch, you have to make sure you do it very carefully, very slowly, very methodically. So what I would be getting into is looking at doing things. If I were treating you as a provider, I would be asking, like, okay, what are the triggers? What are the physical symptoms? And can we manage this with vagus nerve? I'm a big proponent of using vagus nerve, vagus massage. So one way to do that is massaging points around, like, for instance, here you can go round and around, massaging the area around your eye. Close your eyes when you're doing that. I usually do this every morning 10 times, and then go to your ears, and then rub your ears like this, just on the outside and backside of your ear, and do both of them, and you're just rubbing. And I do this 10 times, again, with your eyes closed. And then back behind your head, you've got those two little I call them little knots at the back of your neck there, kind of the axis points, and you just rub those. And I count to 10 when I do this. When you do it, it's helping to stimulate the vagus nerve. The physical symptoms of anxiety decrease. I can just already just now feel myself getting more relaxed. And if you have a heart rate monitor, you can see your heart rate going down. Um, Now that's not long lasting. It'll definitely help kind of set you, and if you're having like very anxiety or ruminating thought, this can kind of help break it up by grounding you, because you're doing an exercise on your body, you're doing massaging, so you're focusing on, the touching aspect as well. Um, so I would be focusing on trying to work on the vagus nerve, doing those types of exercises, breathing exercises with diaphragmatic breathing, and those types of things to see if we can help mitigate those anxiety symptoms holistically speaking. Um, and like I said, with ashwagandha, you just have to be careful, because you had mentioned that in your last question, that may actually trigger anxiety for some people. And perhaps looking at other supplements like L-theanine and magnesium glycinate instead for that type of anxiety. Okay. Also, as I've mentioned in the past, everything got worse after COVID. Yeah, probably brain inflammation there. My system is hypersensitive to every physical symptom that I get and perceives them as threat. Thus, the rumination occurs. Yeah. So definitely, inflammation in the brain, yes. This type of blood work to look for inflammation. There are also studies COVID affected adrenal glands, cortisol spikes. Yeah, that's what I'm hearing as well. Like just in your symptomology, and understanding COVID now. I don't understand COVID. There's a lot I don't know about COVID, and I think a lot of people don't know. We're still learning, but from what I've been seeing in studies with this long COVID, is that it is affecting the brain in the way that uh, decreasing serotonin for some people, and inflammation as well is being shown as a factor. And so, yeah, looking at things that help to decrease inflammation when you're looking at blood tests, CRP, high sensitivity C-reactive protein would be a good one. Interleukin 6 is oftentimes associated with brain inflammation and also like anxiety symptoms, PTSD, depression, etc. So if I'm suspecting inflammation, I look like this type of symptomology. I look at interleukin 6, also SED rate, which is your ESR. And again, homocysteine, because homocysteine is inflammatory and neurotoxic. So I always check homocysteine. Um, Cortisol, if I'm going to look at cortisol and go down that route, I don't like to do cortisol serum because it's worthless, really. You can check fasting insulin. That's a better marker for cortisol, and hemoglobin A1C because of the effects of cortisol. And then you can suspect high cortisol if you have a high hemoglobin A1C with that. But with cortisol, what I'm going to do is do a salivary diurnal cortisol. So getting cortisol samples, in first thing when you wake up, and then a couple hours after that, and then your afternoon time, and then your evening, and then nighttime. So you're getting that, 4 different samples across the day to see what your pattern is. And then by that, if it is related to cortisol, then we can target the times that you're having these cortisol spikes with anti-inflammatories and things that can help bring down cortisol, like phosphatidylserine. So that's, if that's the route we're looking at, that's where I would start digging, at least there, and checking for those markers. Your CBC will also show general inflammation. White counts, leukocytes can become elevated as well, but not good for, like, that's not a good marker for brain inflammation. But just a side note to say that CBCs can show some general inflammation, but oftentimes that's more my marker for gut inflammation. Okay. Dye Film Kitchen, Johanna Sandhofer. Hello. 15 months off benzos, 3 milligrams Ativan a day over 3 years. Okay. So I'm guessing you're taking 1 milligram 3 times a day, but still in withdrawal. Um, Oh, so you're off of it now. Okay, so you were 3 milligrams a day. Okay, got it. Still in withdrawal. Oh my goodness, I'm sorry to hear that. Now I have to take mirtazapine and Seroquel. Oh no, and I'm so afraid of these 2 medications. How hard is it to come off these 2? Oh, again, this is hard to say, because what I'll say is that, when you're 15 months off of benzodiazepines, I would call this more of like a protracted withdrawal. Conventional medicine wouldn't even say that you're still having withdrawal from benzos, but I would recognize it as yes, you are. There's a lot of research out there, benzo reform .com, and then the benzo coalition.org. They have a lot of information on these types of issues. So going there for resources and help. But to your point on these 2 medications, when I say, "Oh, I don't know," is because for some people, getting on medications during their, withdrawal from benzos can be very helpful. But in many patients, it can trigger an adverse effect or adverse reaction. So, and there's a lot of fear that happens with this, and so I don't want to scare you, because I recognize that this is happening, because I see people get better. And then, when they're taking medication, especially if your residual symptom is insomnia, and I can understand how frustrating that can be to want to treat and you want to get a medication on board. But then you're right. Like if it is helping you, then you're going to want to say, well, I now want to come off of this. What does that look like? Right. And unfortunately, when you already have withdrawals from coming off of a medication previously, your risk is actually going to be higher. So someone who just started mirtazapine and never has been on um, an antidepressant before, and that we get them on it for 6 months, their depression resolves, they're sleeping better, and then we taper them off. They're probably going to do well with their taper because they've never had an injury. But someone who's already had an injury and is maybe neuroinflamed, may have a harder time. And so again, I can't calculate how hard it's going to be to come off of them. But what I can say is that if they're helping you and you're getting sleep, you're getting off of over the hump, so to speak, um, you're starting to feel better. Don't take them long term. Take them for 6 months, see how you're doing, see if you're ready to start coming off then, and then do work with a provider who understands how to do a slow, safe, gradual taper, and also who understands what you've been through with the benzo. So a benzodiazepine informed provider, and then someone who understands how to deprescribe and get you off of those 2 medications slowly. And if you were working with me, one at a time. Some providers will do 2 meds at a time. I don't think that is appropriate, because it's hard to differentiate then where the side effects are coming from, where the withdrawal effects are coming from, and what we should or shouldn't slow down. So that's the other thing. You would want to do these one at a time. And if I was looking at someone on both mirtazapine and Seroquel, I would start getting them off the Seroquel first and then the mirtazapine, just because Seroquel has a lot more adverse effects, in my opinion. And in my opinion, would risk versus benefit could be doing more harm than good in the long term. So I hope that answered your question. It's very difficult to predict these things and not knowing the whole story, but understanding 15 months off benzos, in my mind, like I said, I'm thinking you may have some injury going on there from the benzodiazepine. So you just have to be careful. Thanks for the question. Gary, hi Gary. Michelle, I'm sleeping 12 to 13 hours a day. I can easily sleep more. What is happening? Oh, wow. So you're sleeping more. Well, that's a good thing. Gary, I know your history with insomnia and the struggles that you're having. So there's that little backstory just for people live who aren't familiar and then again wondering. So that's interesting that now you're sleeping 12 to 13 hours a day. Um, and you're easily sleeping more. So these are all good things. These are your connections happening. You were in protracted withdrawal for a long time, probably, still are in that post-acute withdrawal phase. But some connections, are occurring here, right? And your body is wanting that sleep because you had a very long time of dysregulated sleep. It's been, several years of dysregulated sleep, and then coming off of the Ambien, definitely disrupted that as well. But I would say that definitely cortisol. It sounds like that is becoming less of a problem now, and that PS has probably helped quite a bit. And PS is phosphatidylserine. And now you're not fighting that excess cortisol at night, is what I'm guessing. And your body needs the extra rest because you haven't gotten a good night's sleep in a very long time. So this is good news. I can't wait to see you on Monday, and we'll talk more about it, okay? All right, Kathleen. I live in Kentucky, 9 months off 40 years of 1 milligrams of Klonopin per day. Okay. I'm 83 and have most of the symptoms with no windows and waning and wanting hope and no doctor. My diet is keto for any recommendations. Okay. Um, well, ketovore, so you're more in that, low carbs and which means you have a lot less gluten intake, because gluten can also be problematic. Now, I don't go down those rabbit holes like some people do with the benzo in the benzo community where they're like, you have to be carnivore, or you have to be keto, or you have to be. I don't do that. And the reason why I don't do that is because, I believe personally that a whole foods diet is the better approach. And what I mean by that is like more of a Mediterranean style diet, because I believe that you do need, some of your leafies for your gut health and just for overall health, etc. But I have seen people leverage like keto in carnivore diets, like a short term, quote unquote fix, and then kind of come back into like a whole foods diet. But really, it's what you can tolerate. And oftentimes, what happens when you get into this, diet sector is that people end up saying, oh, I can't eat this, I can't eat that, I can't eat that, and then they get wild, and now they're only eating like four foods, which we know is not good. So if it's working for you, that's good. Okay. And oftentimes when that is working for you, it's because you're removing gluten, which is a big, factor in a lot of people's mental health conditions. Dairy can be another one. For most people. Now, another thing when you're talking about of things that you can do is, as I've mentioned in other lives and even in my videos with the labs, it's very important to then now look at what else could be going on. Obviously, 9 months off and you're still having some things happening. That's a protracted state. It's not uncommon. So I want you to know there that this is not uncommon, Kathleen. There's a lot of people like you out there, and that. But when I see people in this state, we oftentimes find some things that we can help correct underneath. So whether that's your cortisol is dysregulated because of what the benzos themselves and then coming off of them had done to your adrenal glands and your whole HPA axis and that response system. Oftentimes, that is something that we have to look at. Looking at inflammatory markers, like I just mentioned earlier. So, homocysteine, interleukin 6, your high sensitivity C reactive protein, and seeing if are we looking at an inflamed brain? Okay, how and then looking at anti-inflammatory foods and supplements and things of that nature to help support you during this time. And with cortisol, I would do diurnal cortisol, like I had mentioned earlier. You could look that up. It's basically salivary samples taken over, the course of a day, 4 different samples, different times to look at your pattern. You could also do that with a urine test as well, to look at other hormones, to get a bigger picture. Um, as well. So I would start like kind of looking there and seeing if there's some things we can help to support it. Oftentimes omega-3s can be very helpful in this case. Magnesium glycinate is very gentle and helpful in the nervous system. And the reason why is because I did a video on magnesium, and magnesium, when you are stressed and you're in that HPA axis, meaning that hypothalamic pituitary adrenal axis response going on, limbic system's on fire, right? Bum, bum, alert, 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 everything's kind of going off. That causes that dysregulation with the adrenal glands and with cortisol dysregulation, which causes inflammation. And so therefore decreasing that inflammation and decreasing that cortisol can really help to address that. So you may start to see, some things when you start addressing that HPA axis, that cortisol dysregulation as a factor. And magnesium is used in that HPA axis. Magnesium is one of the minerals that your body will start stealing, so to speak, from your cells to use to help support that HPA axis. And so therefore using magnesium can actually help support that HPA axis adrenal gland system. It can even help long-term regulate cortisol as well. If you're going to target cortisol, to help get it down, especially if it's really high, you can do phosphatidylserine to bring it down, to kind of get over the hump, but you're not going to know unless you look. So definitely looking into some of those things would be something that I would want to do. And then also important that I haven't mentioned yet, that I have in other lives, but I just want to make sure that you realize how important it is the therapy piece and making sure you're working with someone who understands benzodiazepines, understands this process that's going on underneath, how the brain is just like um, completely hijacked, right? And so you start going down very easily those rabbit trails of fear, and your mind, starts to become your worst enemy in that case. And so a lot of the work really with protracted withdrawal is done in therapy and in coaching. And unfortunately, we don't have a lot of coaches and support out there, but there are some. So Angie Peacock, I had her on the channel. We did an interview. She does individual coaching as well as group coaching. David Powers is another one who does a lot of coaching. He actually has a program that is based off of his book, The Powers Manual. So a lot of CBT principles in there and ways to help kind of get that limbic system down, like not be in that hyperarousal state so much. A lot of that does have to do with up in here and not what is the best solution, like what is the best supplement, pill, food, diet. We can go on these rabbit trails on and on and on and on, but really, are we treating what the root cause is at that point, which is the fear? You start to get in a fear state. Am I ever going to get better? And then that opens up Pandora's box. You're now on Google and just feverishly searching for answers. And that just feeds the negativity even more. So if that's what you've been doing, going down that rabbit trail, or anyone else listening, really what you need is support through a coach, a psychologist, a therapist who understands this benzodiazepine, we call it induced neurological dysfunction or injury or whatever you want to call it, that's happening in the brain, to help you with understanding like how to rewire the brain, neuroplasticity, like I was mentioning earlier, vagus nerve can actually enhance neuroplasticity in the brain. You can work on the vagus nerve and really do a lot of good work. All right, so I hope that helped answer your question. All right, Elias. Hi, hello, Elias again. Is persistent depressive disorder harder to treat than major depressive disorder? Well, not necessarily harder to treat. The thing with persistent depressive disorder is it's a chronic condition. It's more chronic and lasts longer. And it's also very subtle at the same time. So, a lot of times hard to identify. Um, but the other thing, too, is when you're looking at the two of them, is that persistent depressive disorder, um, because of its chronicity, oftentimes those patients are the ones that end up being on antidepressants for long term, versus someone who's having major depressive episodes, you know, maybe once every couple years or something like that. You treat that episode, for 6 months to a year, come off the medication, they're fine, right, for a few years, and then maybe it returns, maybe it doesn't. With persistent depressive disorder, it seems to be that it's always there underlying, but very subtle in its presentation. But what I have to say about it is that I've treated patients with persistent depressive disorder without SSRIs, and that was looking at lifestyle, choices, changing, certain routines, for instance, sleep, um, the times that they're waking up, what they do when they wake up, like making sure you're getting light into your eyes, because the sun has a lot to do, in my opinion, with this persistent type of depressive disorder. Um, so light therapy can be very helpful. Exercise, yoga can be very helpful, and so really utilizing the holistic and lifestyle treatments is what I have found to be very effective, because you can do those long term without risking those long term effects that you get with the antidepressants. And starting there is better than starting with meds and then wanting to kind of go backwards. It's harder at that point if you start with medication and then say, well, now I want to change my lifestyle and try to help improve it. It becomes a little more challenging because of the neuroadaptation that was created with the medications, and then potential long-term effects that have occurred because of that. So yeah, I'm not sure that that one is easier to treat than the other, but just know that medication isn't always the answer, and for long term results, you really want to start looking at lifestyle changes and what you're doing as far as lifestyle goes, to support a healthier, to support your mental health. All right, trazodone. Hmm. Liam Keen. Can trazodone be taken only once a day if used as monotherapy for depression and anxiety? And is it possible that trazodone can actually worsen anxiety due to its metabolite MCPP? I do not know about that metabolite MCPP. That's the first time I'm seeing that. I would have to look that one up because I'm not sure about that, or what MCPP would be. And I didn't even come across that in my research. Let me just write that down real quick, because I think I'll lose the comments if I don't write it down. All right, but to get to your question as far as once a day dosing, so you can take trazodone in high dosages if you can tolerate once a day dosing. So oftentimes with trazodone, because it's so sedating and the doses required to treat depression are high dosages. So we're talking about, 200, 400 milligrams, right? And if anyone in this audience has taken trazodone, then you know that that it's very sedating. And so yes, you can technically, but most people will need to do divided doses of trazodone, and and separate those dosages, or do larger dose at night and then a smaller dose during the day, so you're not, too sedated with that. So yes, it can be, but most people can't tolerate it. Even the controlled release version of it, it's too sedating for people. So you would still, they would end up splitting it anyhow. So, and because even if you take the high dose at night, a lot of times people can't even tolerate that because you wake up severe grogginess, that effect that it has on the blood pressure dropping, feeling dizzy, etc. So yeah. Now, worsening anxiety due to that metabolite, like I said, I'm not sure. Um, but it can be used as monotherapy. Oftentimes, higher doses for depression. For anxiety, though, lower dosages for anxiety, because that's where the sedative effects and everything are in, and you don't need to go to higher dosages to get that. So, even doing half of a 50 milligram, like 25 milligrams, can be very beneficial for anxiety. And I've had patients that use trazodone in that way and do fine, and even as an as needed type of medication for to manage their anxiety. Thanks for the question, Liam, and thanks for that insight. I'll have to look into that. Nerd Bama, hello again. Um, Trilozole is a new drug I've read about for OCD. I do not know that one. Um, yeah, you guys are always opening up my eyes. That's one thing I have to say about these lives, but also even in the comments and replies back and forth, is that I learn a lot from you all. And so I appreciate that. And I appreciate every single one of my subscribers. And especially when you're engaging, because as I say in my videos, I always close, it may sound cheesy or whatnot, but it's true. We learn from each other's experiences. And a lot of times what you guys are experiencing and mentioning in the comments about these different medications are things that are not captured in FDA trials, and things that are not captured in short-term trials of these medications. So definitely, helping each other out, and like I said, me learning from you all has also been very helpful. And so I don't know this medication, but I will look into it. Okay. All right. Do we have any other questions or comments? Okay. I guess we don't. No interesting comments out there. Um, I know Raul is back there trying to help organize all of these comments. And I don't know if I've froze or not. I'm hoping that I haven't frozen. Okay. All right. So let's go to the next one. My walkies. Okay, here we go. Can you suggest any other medicine for ADHD for compensating manic side effects of bupropion? I think I answered that one. Can you suggest any other medication for ADHD? Um, okay, because you had asked a question about bupropion causing side effects, and now I think you're asking for like what are alternative medications if you have ADHD and you don't want to deal with the manic side effects. So as far as manic side effects go, like I had told you before, you want to make sure that you're ruling out the bipolar mania, that you're ruling out, like, because that can oftentimes look like ADHD and oftentimes gets misdiagnosed. Okay. So I just want to make sure that you're aware of that. Um, I wouldn't add something to compensate for the manic side effects. I would decrease the bupropion and see what we have left. Okay, because I would want to see, like, differential diagnosisly speaking, differentiate ADHD from bipolar. Okay. Um, Once I understand that better, if I feel like, okay, we're dealing with ADHD and bupropion was just an adverse effect and not that you're bipolar manic, then I would look into, well, the way I do it is labs. What's underneath? Do we have B12 dysfunction, omega-3 dysfunction? Correct all of those things. And if that is not helpful, then start looking at perhaps atomoxetine is something you would tolerate. Lower incidence of mania, though can still occur. Um, Probably wouldn't jump to the stimulants because you had a manic episode with bupropion. It's quite possible you would with others. But if I were to choose one, I would look at Vyvanse or lisdexamfetamine because of its stability and the way that it doesn't do the up and down roller coaster that the other ones do as far as stimulants go. And even Medias is another one that has more of that steady state versus going up and down. So less potential there. But so that's kind of where I would go with that. But first, kind of make sure that we're not dealing with the bipolar. If we were, treat that first, get that under control for at least 6 months to a year, then reassess for ADHD, because oftentimes bipolar looks so much like ADHD. Okay, so let's see. Nirvana, you're welcome. Thank you. I think Raul's going to be coming back in a minute. He had some power problems. Let's see. So come back in here. Marjetta McKinney. Hi. Hi, Marjetta. I know you. We've spoken on the phone before. I'm glad to see that you're here. Is it true that taking clonazepam that you will always take it, even if given for 1 year at 0.5? No, this is not true. This is a lie. Okay, any benzodiazepine, it doesn't mean that you have to always take it. Now, I'm going to back up and say that some patients, seizure disorders, for instance, okay, may need to be on benzodiazepines long term, though there are safer treatments out there that require no medications for seizure disorders, like vagus nerve stimulating device, that you could do. Some patients will be told this because of that, and in that regards, then yeah. Some patients have a debilitating panic disorder, though even for panic disorder, it's stated, short term, while the person is in therapy. Therapy is first line treatment for panic disorder, PTSD, okay, type of symptoms, and anxiety. Benzodiazepines are never to be used. Clinical guidelines state this long term for just anxiety. Okay, so if that's the reason you're taking it, and you want to come off of it, then you have to do it very safely. Now, what tends to happen when someone is on it for a year or more is you become dependent on it, not that you're addicted to it. And the reason I differentiate addiction from dependence, and some people in the comments that I get in these videos, oh, it's still addiction if you're hooked on it. No, because addiction is something completely different. And we have to differentiate the two, especially because of the stigma of addiction. Drug addiction, you're seeking, you're looking, you'll rob someone to get your next hit of if you're hooked on Klonopin in an addictive way. Okay, because some people snort and sniff Xanax, Klonopin, Ativans, etc., because they're addicted, and they will go through great lengths to get their next fix. Okay, that is different than someone who's prescribed a medication that caused dependence because of long-term use. Dependence is a physical dependence. You try to start coming off of the medication, and now you start feeling super shaky. You start having panic attacks. You start having tremors, insomnia, all of these rebound symptoms start occurring. And then your doctor tells you, well, it's just your anxiety coming back. You have to be on this for long term. No, what's happened is that you've ended up in this tolerance and dependence, and what they are going to want to do is increase the dose to keep you in that stage of tolerance or dependence. But you have a choice to come off if you choose to do so. Okay. And that's the other thing, is that you always have a choice, and you have to weigh out the risks versus the benefits. If you are struggling to come off of this small of a dose of 0.5 milligrams, I would recommend getting it in liquid form and doing very small, like 0.01 um, decreases of the medication every like 4 to 6 weeks, and coming off of it very slowly, or switching, if you can tolerate the switch to diazepam. Switching to diazepam, because diazepam is long term. This is the Ashton manual way, okay? For those of you who understand this space, switching to diazepam, because it has a longer half life, you're not going to have the issue with interdosing withdrawal, which happens when you try to cut back clonazepam. Um, Oftentimes it needs to be spread out into 2 or 3 doses to avoid interdosing withdrawal, where diazepam, because it has a long half-life, um, it's just one dose that you would take at night because it's more sedating, and then it's going to have the lasting effects during the day, and then you could decrease from there. And then you would do like a 10 milligram diazepam, and then start by reducing by 1 milligram. By the time you get to 5, reduce by 0.5 milligrams, and you could do liquid once you get to that point. You liquid diazepam. And the other thing about diazepam, and the reason why Heather Ashton used diazepam, not only because it has the longest half-life, is also because it's available in liquid form. A lot of patients have a hard time getting their medication, like clonazepam or Xanax, compounded into liquid form. Or it can also be compounded into lozenges if you prefer. It's like compounded into anything that is less than like a 0.5. So that's your options if you want to come off. But I always tell people that you have to look at as far as the risk versus benefit, right? And your reasoning behind it. Why do you want to come off of it? Do you feel you're at a place that you want to come off of it? Have you been doing therapy and doing really well with managing your external stressors, dealing with your day-to-day anxiety? Because guess what? Anxiety you don't get rid of. Okay. I know we've pathologized anxiety, right? Pathologized, I guess, is the word, anxiety. However, anxiety is part of the normal spectrum of emotions, and it's something that is essential for our survival. So you're never going to get rid of anxiety. It's about how you manage it, and is the anxiety debilitating or not? So I think it's very important that when you're considering coming off of your benzodiazepine, that you ask yourself, why am I doing this? That number one, and that this is your decision, not the doctor's decision, not your boyfriend or husband's decision. This is your personal decision. Then number two, am I at a place where I can manage my anxiety, or is my anxiety still a mess? If your anxiety isn't being managed well, you're not managing your external life stressors, if you're still having panic attacks, get that under control, start managing that. Then when you're at a place of stability, then again, go back to asking your question, like, why do I want to stop this? And am I ready to stop it? Okay. Some people want to stop it because they're experiencing adverse effects. Some people want to stop it because they have the long-term issues, like the cognitive issues, the imbalance issues. Some people want to stop it because they want to have a child and they don't want to be on medication, right? So there's a lot of reasons to want to stop it, but you want to make sure you're at a stable place mentally as you go through this process, because it's going to challenge you when you start tapering. Even when you go slow, okay? When you go slow, you're helping to reduce the major, things that can happen with withdrawals, and the intolerable withdrawals. Those symptoms tend to be shortened and less going slow, but it's not unavoidable. So you want to make sure you have a lot of tools in your toolbox to be able to manage that anxiety that can occur and arise during the withdrawal. So very good question, and I'm glad that you asked it, because there's a lot of misconceptions there about it. And I know that was a long answer, but I think it's important to answer it. All right. Okay. Are you going to make a clozapine? Um, Clozaril. I've thought about that. It's actually on my list. It's, and the reason why I haven't is because it's one that I don't use, because of the REMs and all of that. But I can talk about that in the video just fine, and talk about, um, risk versus benefit, like I do, how it works, what it's used for, the side effects, things to consider. And I'll go back and see if I have enough comments on it. It seems like this has come up a couple of times. So yeah. I wrote that back down on my list, and I'll look and see where it is on my queue. But if I get a lot of requests for a video, that kind of bumps the other ones down. That's why I do those, like the Adderall, the Vyvanse that I did, and even the one on Ritalin that's coming out next week, is because there've been a lot of questions about those. But yeah, so I'll look at clozapine again as a medication video. Thanks for the suggestion, Noah. All right. Let's see. Do we have any more? MXC455. One of the horrible side effects I receive as feedback from my patients who are on SSRIs, SNRIs is emotional blunting. So are there any treatments for that? Okay. This emotional blunting has to do with too much serotonin in the hypothalamus of the brain. So I'm guessing you're a provider, so you kind of understand where this is coming from. But treatments for that, reduce the dose. So consider reducing your dose. If it's something that can be paired with bupropion, oftentimes that is what is done to help, because they need a little more dopamine. So it's like this seesaw game that we're trying to do. But if you know me, maybe you don't, asking this question, you know that I wouldn't go down that rabbit hole of adding more and doing all this that conventional medicine does, because I believe that we end up doing more harm than good. So I like to look at the root causes, look at what else is going on. Why are they responding this way? Maybe we should decrease and look at nutritional support. So doing those labs that I mentioned in the mental health labs video would be beneficial as far as that goes. So though there are really no treatments for the emotional blunting except adding something like a bupropion to give dopamine, or some providers will even do stimulants. But again, I think we go down rabbit holes when we do that. As far as now we're adding more of those risks, those side effects, and setting your patient up for treatment resistance and being labeled as treatment resistant and all of the problems that go with that. So what I would challenge you to do is to start looking outside the box, and asking asking some deeper questions to your patients. What are they eating? What are their lifestyle choices? How are they sleeping, et cetera, and try to treat it from that angle versus just going down the pill mill avenue. And I know it's hard if you're in an insurance-based model, because that's kind of what we're forced to do. But just something to think about, and to question that type of practice. It's okay to question it and to critically think outside of the box. Okay. So that would be my advice to you. All right. Did we lose questions or something? I think that's why they may be coming up this way. Okay. Is it safe to be prescribed two ADHD medications, such as a stimulant and non-stimulant? Can both medications be taken together? Stimulant and a non-stimulant. Okay. It depends. If it's just for ADHD, okay. So with these combinations, so a lot of times providers will have bupropion and, say, Adderall, or maybe Vyvanse or something like that. to leverage, more of that dopamine enhancement, et cetera, for treating ADHD, especially when you reach your max dose of an ADHD medication, and particularly a stimulant, and need a little bit more quote unquote help. Mhm. Though it can be done, I do it with caution if I'm gonna do it, because again, like I just said to that provider in the last comment, you have to think of what rabbit hole am I going down, right? And wouldn't it be better to if you're at, like, say you're Adderall 30 milligrams a day and oh, we're maxing out, or maybe you're maxed out at 40 because technically you do 40. So let's just add bupropion. Well, hold up. Wouldn't it be better to maybe come off of the Adderall for some time, maybe slowly reduce the dose, kind of learn how to manage your ADHD symptoms, and then resume it? And now, now you realize, oh, it's actually beneficial, or only use it when you really need it. If you're working on a long project, or you're in school, et cetera, having to study, kind of managing it in that way versus going down the path of treatment resistance. Because it can happen with ADHD when you're on so many meds, and then eventually you do have to come off. You can't, and so there is a limit. The other thing is with these other ones, non-stimulant medications, when you're looking at adding something like atomoxetine or Quellbri, now you're dealing with a lot of inhibition, like CYP2D6 inhibition and side effects and things of that nature that you now have to be careful with drug interactions. And now also serotonin syndrome is a risk. So there, yes, there are a lot of risk. Is it being done by providers? Yes. Is it something that I recommend? No. Look for other ways to help manage your symptoms of ADHD. And also those labs that I talk about in my video on mental health labs. If you have low B12, low folate, though I talk about in the methylation cycle serotonin, it also rings true to dopamine, via the S-adenosyl methyltransferase, the SAMe part of that cycle. So that could be getting disrupted. So that's what I would be looking at there, is looking at what could be causing, your symptoms of ADHD. What is your diet like? What is your lifestyle like? And then going from there. So yes, that it can be dangerous. Have providers done it safely and patients have been safely prescribed to, like, a non-stimulant and a stimulant? Yes. But long term, is it the best treatment for you? Probably not. So that's my take on that, Deanna. Irene Neo, can you recommend a dosage of magnesium for anxiety for a woman in her 30s dealing with severe anxiety and depression? I don't want to take any medications. I have PCOS and CPTSD. Okay, so PCOS, you're dealing with hormone issues, probably lots of pain. So with magnesium, when I use is magnesium glycinate, and I start at 200 milligrams and increase it. 200 to 400 milligrams will be the dose for most people. However, I've seen patients use up to 800 milligrams, and personally, like in my practice, I've seen that. In research, 1200 milligrams. The thing with magnesium is if you're taking too much, you're going to know it because you're going to have loose stools. So that's another way to kind of updose until, if your limit, you're going to have, end up having loose stools if your kidneys are functioning well, excreting it, etc. If your liver is doing what it's supposed to do, that's typically what ends up happening with magnesium. But yeah, so I'd start at 200, to 400 and kind of see your effectiveness about 2 weeks in, kind of gauge how you're doing. And you can also do that dose a couple times a day. It doesn't just have to be in the evening time, though most people use it in the evening because it helps to get them relaxed, to help them sleep. But you could actually, do 200, during the day or in the afternoon, whenever your anxiety is at its peak, and decrease it. But also looking at, I mean, obviously with CPTSD, you have trauma. I would look doing somatic therapies, which is like some body work. There are a lot of great therapists that use yoga and different, like vinyasa type, like slow body stretches and body work to help release anxiety that gets stored in the nervous system as a result of complex trauma. And so that is what I would also recommend to you, going the holistic route. With PCOS, looking at a Dutch test, and Dutch plus, because you want to also assess your adrenal glands, because a lot of times that can become dysregulated with PCOS, and then see if there's anything you can manage there, because that could also be very, very helpful for managing your anxiety. But I really think with that CPTSD component, if you're not already in somatic therapy, that somatic therapy could really be helpful for you because of the way that trauma gets stored in our bodies and our nervous system. A good book that helps to really put this in perspective is The Body Keeps the Score, by Bessel van der Kolk. Um, that book is a very good book that it kind of explains a lot of this. But yeah, so look into some of that too. I hope I answered your question, Irene. Thank you. Alex, is magnesium enough for mood disorders? Magnesium is going to be more for helping with anxiety and the stress response, though it has 300 enzymatic reactions and is involved in over 300 enzymatic reactions that we know of, and is very important for cell signaling, neuronal cell signaling, and a lot of other things in our body and our brain and nervous system. Would it be enough for mood disorders? Oftentimes, no, unless you were very deficient in magnesium, and that created a type of mood disorder. If you're looking at natural treatments to help with mood disorders, again, Alex, that saying that you ended up going through your root causes and looking at labs, etc., done all of that and kind of ruled those things out. Lithium orotate tends to be very helpful. And this is not pharmaceutical lithium. This is, your natural, mineral lithium. Okay. In small dosages can be very helpful. And there's a website that goes into the reactions as far as interactions or the effectiveness of lithium, mechanisms of action. That's what I was thinking, and I got kind of had a brain thing going on here. And that would be under Psychiatry Redefined website on lithium orotate. I'm not sure if Raul's able to put that in the chat. I have a link for that. Hopefully he can find that and put that in for you guys, because that can be very, very helpful to kind of just get you going on understanding lithium and its many, many, many benefits. And I also have this book that I always talk about too, Nutritional Lithium. This is his book. Oh no, I think I lost my camera. Sorry guys. That's me. I just bumped my camera and I think I messed it up. Hold on. See if I can get it back online for you. Just give me 1 second. I'm going to stop my mic and cam for 1 second to just. Yeah, I came back. Okay. I'm so sorry about that. I was trying to reach for this book and I knocked this cord. So I'm sorry. Nutritional Lithium, this book here by Dr. James Greenblatt, very, very, very informative on that. But a lot of the stuff in this book is on that website page that I'm hoping we can get up here to post. Okay, so that's what I would recommend. Look for root causes. If you kind of already went down that path, then lithium orotate, natural supplement that can be used to help. In conjunction with magnesium too, by the way, and omega 3s. Um, Nikos Charalambous. Okay, Nikos, 33-year-old male diagnosed with panic disorder and PTSD since age 10, was on paroxetine 20 milligrams from 17 to 32. The only major health issue I had in that time was COVID on 2 occasions. Okay. Is Effexor XR 300 milligrams once in the morning and mirtazapine 15 milligrams at night, high doses for moderate depression and anxiety panic, was put on this because paroxetine probably stopped working. So that was what, 300 milligrams? Okay, thank you. And 15. Well, for moderate, okay, with this dose of Effexor, what the provider is trying to accomplish here is trying to get more of the SNRI benefits of Effexor. Like I had mentioned earlier, to Nerd Bama with this medication, once you start getting above like the 225, 250 range, you start getting into targeting more of that norepinephrine and really leveraging that, which can be very helpful with depression. So going at 300 milligrams, you're definitely in that regards. Now, when you add mirtazapine, what this provider is doing is it's called California rocket fuel. That's what, Dr. Steven Stalls calls it. He's like the conventional, psychiatrist that's written our books on prescribing. Okay, so that's where that comes from, right? And he's got other books as well. But so what the provider is trying to do is leverage, and the reason why they called it the rocket fuel is because of the multimodality, meaning the many ways that mirtazapine works in the brain. It can also enhance norepinephrine as a downstream effect, though it's recognized as a serotonin modulator, right? Or multimodal antidepressant. And so when you increase that with Effexor, you really help to leverage that for depression. Oftentimes, this combination is done or reserved for a more severe depression, okay, and anxiety. But because you have that mix of anxiety and panic disorders, why I'm guessing that they decided to do this, because I imagine that your presentation and your symptoms are probably very, very severe and very pronounced. And so that's why they have done this. So, what were you saying? Is this something that would be like considered out of the norm? No, it's not. This combination is often used. However, like I said before, start asking yourself, what is your lifestyle? How are you eating? Are you eating clean foods, right? You don't have to completely change your diet. You don't have to completely go keto. You don't have to go vegan. You don't have to, be radical, but stop eating foods from a box. Stop eating high fat foods. Eat clean. Those things, a lot of people don't like to hear that, but it makes a huge difference when you do that. When you start eating clean, your brain is happy. Okay. Maybe you need to eliminate gluten or dairy, play around with that. Look at your labs. Are you deficient in vitamin D? Is there a B12 deficiency, folate deficiency? Is there inflammation, right? Is there thyroid dysfunction? Look at what could be going on underneath as well. That is very important, and I can't underscore how important that is, like, anymore. I know that I keep going back to that, and that's because I don't practice conventional medicine, but I understand where you guys are coming from, because you probably don't have access maybe to unconventional providers or integrative mental health providers, because of the way our medical system is set up. So I want you guys to do that critical thinking and start thinking outside the box of what else could be contributing here, because you keep going down this rabbit hole, though it's very acceptable in practice, is that eventually you end up needing maybe a little bit of this. Maybe let's throw in a mood stabilizer in there. And oh, you know what? Let's add in an antipsychotic. And you know what? We probably have to go to a Z drug like Ambien and really get you sleeping a lot better because now that's disrupted. Hold on, right? Stop and start to think, you know, is it because now the medicine stopped working and now maybe you're having reactive effects to the medicine, et cetera? So though this combination is acceptable and is used by many conventional medicine practitioners, it can set you up to go down that rabbit hole of that leads to polypharmacy and being on multiple medications at a time and having a lot of adverse effects as well. So just something to consider, okay, Nikos. But right now, like what you're on, like it's acceptable. It's acceptable practice and can treat, you know, your symptoms. But there are other things you can do before going down that rabbit hole of adding more medications that you can leverage, that you can do naturally with lifestyle changes and things of that nature. Okay. Oh, nobody's fault but my own. I need any and all help for major depression. I'm on Aristata, but it barely helps it. And now I just started Vraylar 3 milligrams. Um, I'm not sure. I'm guessing this is a part of that other question, maybe. Um, okay. But then that would mean you would be on effects from mirtazapine, Aristata. That's too much. Um, Okay, so yeah, if this is the same person, I'm very confused because there's no thing with this comment here. Then you're already on that rabbit hole, and so definitely going back to the root causes, what's going on, why are you needing and requiring all of these different medications? Like I said, it's most likely a result of the long-term use of them, and perhaps even having adverse effects from those medications and side effects that look like um, a condition. And then another medication gets added because of that. I did a video on how medication harms, and that was with Angela Peacock. She's the coach that works on deprescribing and helping patients, you know, dealing with withdrawals from either benzos or even like antidepressants. But very good video to talk about how she ended up on 18 different medications. This is how it happens. So start asking those questions and start stepping back. And if you're not able to work with someone who can help you, and get a support system in place, a loved one to kind of help you. Because oftentimes when you're in this, you're in the weeds, and it's hard for you to be the person outside looking in on what else could be going on and things that you can be doing besides medication and going down that path of a pill for every ill. Unfortunately, when we go down those paths and when that happens, um, it leads to this polypharmacy, eventually labeled treatment resistant, and now you're going in for ECT, you know, electroconvulsive treatments or something like that. So just kind of think about that, okay, as well. Isaiah Sells. Hi, Isaiah. I take 10 milligrams of escitalopram. It has a score down the middle. Is it safe to cut in half and take 1/2 a day? Yes. Yes. Even if it's a generic brand that doesn't have the scoring down the middle, escitalopram is safe to cut. And you can do that and take, you know, if your provider's saying it's okay to do it, or, you know, if you're in a place where you're ready to come off of it. Depending on how long you've been on it, though, if you try this and you don't do so well, you may end up needing the liquid form and coming down a lot slower and doing like 5 to 10% cuts instead, which you can't do really with the cutting. It's hard. I mean, you can try cutting it in fourths maybe, but you know, kind of at this point in time with the 10 milligrams of escitalopram, cutting it in half may be too much for you, depending on how long you've been on it. So if you've been on it for more than a year, like looking at 2 years, 3 years, 4 years, you know, that's when it becomes a little tricky. But I was able to get someone off that was on for 6 months. Um, not too long ago, and we ended up doing it, cutting it in half, and then we did every other day dosing for a month, and then now he's off and he's doing great. And he came off of Lexapro and Seroquel one at a time. We did Seroquel first and then Lexapro. So you can do it. You can help treat them for 6 months to a year and get them off medications. That's what I do with my patients. I try to focus on not, the holistic things and not making them dependent on the drugs nor dependent on me, because that's also what this kind of system ends up doing. And unfortunately, it becomes lucrative for the provider to keep you on medications, not to take you off of them. So there's that component too. But anyway, you could safely do it, cut it in half and start taking it, and you could tolerate this if you've been on it, not a long time. And then I would say from there, do every other day dosing and then try to come off of it. Like I said, I've done it before, just recently did it, and have done it even before that patient. But if you're on it long term, it's going to be a little trickier, and you may need to go to liquid and do smaller cuts. Okay. All right. That was Isaiah. Non-Vera, is it possible for you to talk more on hypnotic meds for sleep, non-diazepam route? Yeah. Where do you think the medication will be in the next 30 years? My insurance offers transcranial depression. Do you see things like that? Yeah, definitely. There is a movement happening right now. And maybe it's just because I'm involved, like I'm in it. I'm in the weeds. But I'm starting to see, a movement where, providers are wanting, to look at other things that could be going on and not, drinking the Kool-Aid, so to speak, right? And saying, okay, big pharma is pushing all of this, right? It goes to our education system, which then comes down to us. And then, but we have our own minds. We're able to critically think. And once we start questioning the status quo and questioning the model, right, which more and more providers are doing, then we start looking at treatments like this, transcranial stimulation. Yes. TMS, very effective. Yes. Vagus nerve stimulation. Yes, 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 yes. All non-medication treatments, right? And looking at the person's lifestyle. And unfortunately, what I think is that we have gotten so used to as a society, and maybe it's those commercials we get from the drug companies, right? To do, to have in our minds a pill and everything's fixed, right? And unfortunately, that's not how it works, because Z drugs, which is what you're talking about, the hypnotics, I call them Z drugs. So I mentioned like Ambien, right? Which is like Zolpidem. Then you have Zolpidem or like Lunesta. All of these other like different hypnotic type of medications that are non-benzodiazepines are just as dangerous, if not more dangerous, than the benzodiazepines. And the reason I say that is because when you get tolerance and dependence to those medications, it is a lot harder to come off of them, at least from what I've seen, um, than the benzos, because with benzos, you don't always get rebound insomnia or insomnia. But from what I've seen in the patients that I've helped come off of those Z drugs and those hypnotics, they tend to always end up with that rebound insomnia. And it's hard. And even when they come on and they're off of it, and it's very, very, very challenging and hard to deal with that as a symptom, because we need to sleep, right? And then that creates that fear and that remodeling of fear of, that limbic system with the fear of sleep and not sleeping, and then associating your bed, and then becomes a very strong signal with those Z drugs, and takes a whole lot of therapy, and someone who's also very resilient and able to do the work, okay, and not look for the quick way out. There is no quick way out. There is no, supplement oftentimes that can help with this when you're dealing with someone coming off of hypnotics. it's really a lot of the mental health work that needs to be done, the psychotherapy, sleep coaches that do CBTI that are really good. There's one that I've been watching. His name is Daniel. He's a sleep coach. He has like, I think it's called Sleep Coach School or Sleep School or something like that, on YouTube. But he has, and he has worked with a lot of patients who come off of like medications like Ambien and the benzos, etc. But I would say, just from, and maybe it's just because I don't have that much experience as maybe other providers do with deep prescribing, but from what I see with the hypnotic drugs, so far those have been the most difficult for me, the dealing with those patients. So that's why I say they're the worst to come off of, in my opinion. You know, and I've only been doing this, helping patients deep prescribe for the past 2 years, you know. But that's what I've been seeing. You know, I haven't found one that's been like, oh, this is just easy, this is great to come off any of those. And the other thing too with those Z drugs is that it's hard, the hypnotics, it's hard to get them compounded, even harder than the benzos to get. So there's that part too. But yeah, I think that in 30 years from now, my prayer is that we stop relying so much on medications as the fix, and we start looking more inside of ourselves and looking at things that help with neuroplasticity and getting the nervous system to calm down, because oftentimes that's what a lot of this is from, an overactive nervous system, especially if you've had trauma. I mean, there's tons of evidence to prove that gets stored in our nervous system and the limbic system of our brain. It kind of goes haywire, and it's, you know, and those types of things. But that also occurs with the benzo group, and coming off of them, and coming off antidepressants, and you know. So yeah, I do think that providers are starting to move more towards looking at other avenues besides medication. And hopefully, if we need to use medication, we're thinking short term while we fix some of the underlying things, and then get them off of, you know, like I do and continue to do with my patients and have done with them. Okay. Alex, a lot of pharmacology questions. What about CBT? Exactly. I get a lot of the pharm questions because my channel is a lot about medications, and that's kind of what you know, the audience, you guys have been wanting, is a lot of that. And my holistic playlist doesn't really get a lot of cred or visibility, whereas all the medication videos do. And so that's why. But yeah, CBT, like I was saying, with Daniel, he's a CBTI, you know, certified, you know, therapist, and does sleep coaching, and that uses cognitive behavior therapy. And like I said earlier, when I was answering those comments about the anxiety post benzo withdrawal, a lot of this is fear based, right? And you have created pathways that now we naturally go to fear and negativity as a defense mechanism, like as a protective, I guess I would say, mechanism. But when you're in the throes of benzo withdrawal or post withdrawal, and you're still experiencing like you're off the med and it's still happening, those tracks, those pathways become stronger. That fear signaling is much stronger. It's more heightened, right? And your nervous system, like I was saying too, gets hijacked with all of that. So there's a lot going on now. We don't completely understand it all. I mean, we have this terminology that tries to explain it all, the benzo-induced neurological dysfunction, but we really don't understand it all. Like, we haven't observed all of the brains of people who have been injured by you know, benzos and even other medications, because it's not just benzos that can cause this. But yeah, CBT therapy, cognitive behavior therapy, very helpful, because you're unlearning, you're learning to unlearn and rewire the brain to think differently. But the thing is, and why a lot of people want the medication. What about this med? What about that med? What about this med? Is because they don't want to do the work that is required for CBT to be successful and the time. Everything's about instant. And again, that goes back to our society, the instant fix society. And that's that's what we're in. And so when we're looking at this whole system, I guess we want to call it, of psychiatry, this whole medical model, I guess, um, it's medicine driven because that's what the consumer is asking for. So back to the question before too, Alex, as I'm answering this one here, um, about where do we see this 30 years from now, et cetera, is it's not just the practitioners that have to make the shift. It's you all. It's the consumers. You need to start asking questions. Why am I looking for a quick fix? Why am I looking for a pill? Start questioning these societal norms, right? Because you together is how we make the difference, and start looking more towards CBT, lifestyle, changes, right? Diet, nutrition, exercise. No one ever wants to talk about exercise. Oh gosh, I have to exercise. Even if you walk, they've shown, there's studies out there. People who work at a desk like me, I'm at my desk all the time. I have to carve out time to go for a walk, to get out, even if it's 15 minutes. That is considered exercise, and that's going to help prevent me from getting more anxious or even becoming depressed. Just going for a walk for 15 minutes a day, stepping outside, getting fresh air, sunlight. It's back to basics. But most of us don't want to do that. We don't want to look internally and say, uh-oh, maybe, we've kind of created this monster that's going on, the rumination, the fear. How do I uncreate it, right? We don't want to ask that question, like, how do I undo this? Because it takes work. And then some of us have a lot of fear of even stepping outside, and then there's that agoraphobia. That again was created from fear. And oftentimes that is fear of what's going on with the benzo withdrawal or the antidepressant withdrawal, et cetera, that kind of paralyzes us, or even fear of trauma that paralyzes us. So yeah, it's complicated. It's multifactorial, but as a society, we all have to start looking outside of pharmaceuticals and looking outside of that as the end all be all quick fix. And remember, it took for most of us a long time to get to where we are. So we can't expect in an instant things are going to miraculously recover and be perfect. It's going to take probably just as long to heal and go on that healing journey. So that's my soapbox. GGC, if on 40 milligrams of Remeron and it's not having the effects of increased appetite, should the dose be lowered to 7.5 or 15 to have the drowsiness and appetite? Yeah, okay, so good question. And I have a video on mirtazapine about this. So lower dosages are going to have more of the sedating effects. You're targeting more of the histamine here. But yeah, absolutely, that's going to help with not so much. I'm not sure about the increased appetite you'll get in any dose. Maybe I guess a little bit more at 45. I'm guessing because you are getting more norepinephrine there, which can maybe hinder the appetite a little bit. So theoretically speaking, I guess so. 7.5 to 15 milligrams. Yeah, definitely going to get more sedation with the lower dosages. Absolutely. And I'm guessing, yeah, increased appetite, especially if you're up to 45 of Remeron now. So thank you for the question. What if SSRI doesn't work for anxiety? Yeah, so if SSRIs aren't working for anxiety, again, like I'm mentioning, and you probably are familiar with this theme by now, did you do your homework and look underneath the hood? Did you look for your maybe nutritional deficiencies, inflammation markers, maybe your thyroid, estrogen dominance? All kinds of things could be going on that can lead to this anxiety or treatment resistant where medications don't work. So kind of looking there first is what I would say. Absolutely. Adjuncts that you can try, omega-3s, tons of studies can be helpful. More for depression, but can help with brain inflammation if that's where the anxiety is coming from. Magnesium, I mentioned that already. Magnesium glycinate, very, very helpful and very well tolerated. Um, Vitamin D can also help, especially if you're low. That's where it's shown research wise to be the most. So making sure you're checking for these underlying deficiencies and not just randomly taking them. Um, However, randomly, like just taking omega-3s, and even if you're not deficient, or magnesium, have been shown to have benefit. Okay. Whereas stuff like vitamin D, it's more if you're deficient. And so taking an individual approach there. And even looking at things like L-theanine, an amino acid that can be very helpful for anxiety, and other root causes, methylfolate, are you MTHFR or not? Um, B12, the low B12 often leads to depression and not anxiety. But lots of things to consider if you're in that rabbit hole where SSRIs don't work. Um, and doesn't mean you have to go to a benzodiazepine, though most providers will say that. No, it's not true. You've got to look underneath and look for other things. You can also consider SNRI, but again, I like to look underneath first and kind of determine if I'm dealing with anything else. Is it cortisol? Because cortisol is another one that can be very hard to treat with anything. And benzos can, like I said, because that's on GABA and all that, but long-term effects of that, do you really want to go down that rabbit hole? If you spent any time in the benzo forums, then you would absolutely say no. And that's looking at like benzo buddies and things like that to kind of see all of the people that are suffering. There's hundreds of thousands of people who are suffering because of benzodiazepines. And that number just keeps growing because more and more people are being prescribed. So though it's not a majority of the people that get put on them, right? Because I believe I saw a statistic where there's like 30 million people prescribed benzodiazepines, so you have a few 100,000, that's, when comparatively speaking, a drop in the bucket. But do you want to risk that long-term issue and effect that can happen? And a lot of you who are here in the comments section and watching have been affected. I know, because I know some of you, and you guys can speak to this. So just in our small audience live watching now, there's a few of you that have been affected by benzodiazepines. So I think that there's probably a lot more than even what we see in the forums that are suffering. Those are just the numbers that we see in forums. So there's people who aren't in those forums that are suffering and suffering alone. So anyway, so that's my, I guess, another soapbox. Sorry, true human, but yeah, if SSRIs aren't working, look for root causes. I have a video on that. It's called Why Antidepressants Don't Work. And then the one on mental health labs. Both of those will kind of help you to start at least looking for other things. And CBT, like that one, I think it was Alex said, why aren't we talking about CBT? CBT, therapy, do the work. But sometimes it's hard to do the work if you're, in the acute phases, I understand. Anupam Sin, Prozac 10 milligrams weekly for low to mild depression. Okay, so 10 milligrams weekly, this is interesting because Prozac has a very long half-life, and I've seen patients do this. Now, there's also a weekly medication for Prozac. So I don't know if you're talking about the weekly medication or just taking like the regular Prozac for a week. But that can be done, just like I said, because of the long half-life. Now, if you're doing the weekly formulation, it's formulated, to be released, weekly. So that, and that has shown lots of benefit. I think it's one of my most popular videos, the one on fluoxetine. I have the video on fluoxetine, though I don't really differentiate between the longer acting and not. Both, have shown efficacy, and it's one of the most common antidepressants that are prescribed. And the reason why is because it's relatively well tolerated when you're looking at, you know, millions to billions of people that are prescribed this. And those having reactions are a lot less. And also looking at the whole scope of the prescriptions. Not only is it more well tolerated, it's also one of the medications that has the least risk for withdrawal syndrome. So, not saying that it won't cause a withdrawal syndrome, because there are people that will have a withdrawal syndrome. I see them popping in my comments here and there, but that's not a common thing because of its long half life. And if I do have someone who's having issues with fluoxetine and withdrawal, definitely. Well, I always work on root causes, but if someone comes to me after saying they've been having withdrawals off of fluoxetine, that's a huge red flag for me that there's definitely something else going on underneath, because it's very rare to have that. And then if you fix the underlying issue, common ones I see for that are going to be methylfolate. So low folate, high homocysteine, super common for that. And low magnesium, low RBC magnesium, high copper, low zinc is another one. Reason being, looking back, is like kind of thinking the way they all work, is that those are cofactors that are required, for proper serotonin synthesis and production, et cetera, to kind of keep that balance. And so anyhow, I just went down a whole rabbit hole of that. But yes, you can take 10 milligrams of Prozac weekly, and is very well tolerated either by the weekly or the one, or just a regular, because it can stay in your system that long. However, if you're doing the regular one, it usually will start wearing itself off. Like it actually starts tapering itself by day like 4 or 5, somewhere around there, it starts tapering itself off. So the effectiveness towards the end of the week may not be as great. All right. Martin, Piel, hello, Martin. What is the difference between paliperidone, 3 milligrams in the day, 3 milligrams at night? Okay, so paliperidone and Vega, so that's twice a day, and olanzapine, 2.5 milligrams. Oh, okay. So basically, the difference between paliperidone and olanzapine. Well, they're both atypical antipsychotics. Both of these medications. The difference really, when you're looking at the two of them, I believe olanzapine has more serotonin, especially like the 5-HTC antagonism. So that's why it's more useful for depression, type bipolar, right? And in combination with fluoxetine as Symbyax, because of that, and it helps to improve that effect or action in fluoxetine, right? So that would be the other main difference between these two is the level of sedation. So your olanzapine is going to be more sedating. Now, milligram to milligram, I can't really say because I'm trying to think, because I'm trying to go back to my community mental health days, and I did have patients on Invega and olanzapine. I do have a few patients even now on olanzapine, so I'm more familiar with that. And I do know that olanzapine is more sedating for sure, but milligram by milligram, I can't. I don't know if they work like the same, like as far as like is 2.5 equivalent to like a 3 milligram. I can't really say that off the top of my head. I don't think so. I want to say you probably would need a higher dose of olanzapine to get that same equivalency of paliperidone, as far as treating like psychotic symptoms, manic symptoms, those types of things. But paliperidone or Invega is going to be more for schizophrenia, bipolar, mania, is where I have used it. Not now, because my patients now are more depression, anxiety, though I have a couple of bipolar patients that I treat as well. But so some of them, do really well on a little dose of olanzapine. But paliperidone, when I worked in community health, we did use it. I did use it, and mostly for my schizophrenic or bipolar 1 patients, and it's very effective. But I would say the main difference here would be like the serotonin antagonist, 5-HTC, to help with the depression symptoms, uh, leveraging olanzapine more for that. If you're looking at both of them for bipolar or schizophrenia, then it's whichever one you can tolerate. For like the manic, bipolar 1 mania, or schizophrenia, then it's whichever one that you can tolerate and gives you the least side effects. Both of them come with a lot of side effects. So it's going to be weighing out that and what works best for you. Okay. Again, always, considering your root causes, nutrition, lifestyle, and hopefully you're in therapy. Thanks for the question, Martin. Jermaine Denon. What should I do if I have protracted withdrawal? Here we go. Here's another one. See, I told you they're out there. From psychiatric drugs. Becomes bedridden and brain is non-functioning. All this after a few weeks of medication for anxiety. That is unfortunate. Just for a few weeks. Yeah, the common trajectory is like that protracted happens is from like long-term use. But in Jermaine's case, I have seen it occur with just a few weeks of medication use and psychiatric drugs. So that means we're talking that this could be benzos, or it could be antidepressants, or, antipsychotics, mood stabilizers, whatever. So what should you do? Well, first of all, the whole bedridden thing, and because your brain's not functioning, that becomes where a lot of this stuff starts to. Remember, I was talking about the pathways. I don't know if you were here, because I've been going on for a little while with the pathways of the how your brain creates pathways of fear, right? And a lot of it has to do with this whole thing in bed. And now you could end up leading towards agoraphobia, where you're now afraid to even step out of your house. This is how it starts. So I would encourage you to get out of your bed, as difficult as it may be, even if it's to get out of your bed and sit. Maybe there's a chair next to your bed. To get out of your bed and walk to your bathroom and brush your teeth. Just do one, like start with one thing at a time, because being sucked into the, oh, I'm so ill, I just have to be bedridden. There's a lot of people out there that say just rest, just sleep it off. And no, I don't think that's the right way to go, because I see that those patients tend to have a more difficult time to come out on the other side. So, and I know it's hard, and I'm not downplaying the fact that it's hard, and you probably feel very weak. I've had a patient recently who's doing much better now. We actually ended up working on her gut. Her gut health was one of her root causes, and doing much better. Inflammation down, much better. But I remember when I first started working with her, she was like, "I'm so weak. I don't think I can get out of bed." And it took a lot of effort and work to challenge that thought, and to get her to get out of bed, and to get her to start going to the bathroom, to walk to the bathroom, to not in her pants, right? And to do these things, right? And to start challenging that, because a lot of that is also the fear, right? What if I get out and I fall? What if I do this? So having the support systems in your place, right? And making little steps. So that's the first thing, is don't allow yourself to be bedridden by this. Make an effort, a diligent effort, to get out of bed. Okay. Unless your limbs are broken. All right. You can do this. Okay. I promise you. And the other thing is that to remind yourself is that you will heal. There's a lot of fear out there in the benzo community, and a lot of people end up in this cycle of, I'm not going to heal. I'm not going to heal. I'm not, I'm treatment resistant, or whatever it is, and blah, blah, blah. But you can, okay? And also look at root causes, though that can take you down rabbit holes, I understand, but I think it's important, okay? And there's some people who are against this, but this is how I've helped patients. Like I said, the one lady who I was just talking about, she had a lot of yeast and mold in her gut. It showed up in her stool sample and in her oats test, and we had to find the source, which she did. clear that out. So it was a lot of root cause and then worked on her gut, and she finally started feeling better. Now, this wasn't an overnight fix. This was what, about 6 months finally she started feeling better, and is now doing she's actually driving now, like, she's functioning, she's getting out, she's doing things, she's functioning. She's still having some symptoms, but she's functioning. So my point is that, there are things that could be going on, okay, but I don't want you to latch on to what happens when you're feverishly searching for things on, oh, it could be this, oh, it could be that, oh, I heard it's mast cell, oh, I heard it's this, oh, I heard it's that. That's when you can go into this whole really, really bad, like health anxiety and things of that nature. So it's best to work with someone who understands root cause mental health and can actually do the testing, understand how to read the test and work with you, instead of you doing the research yourself and getting paralyzed by all of the things that it can be. Okay. But oftentimes, if it's this severe, and especially over a few weeks of taking a medication causing this, there is something going on underneath. There is. And a lot of times it is other things, like in her case, mold, and then the gut. And then in other patients that I've seen, Lyme, but I don't want you to scare yourself and think that it's all these things and do all these treatments. Look, you have to look under the hood first. So that's what I would say. And start working with a coach, a benzo coach, or one that understands medications. Now, benzo coaches, like I said, like Dave Powers, Angela Peacock, but Angela Peacock also does other medications, and she's the one that I interviewed, and she was on, I think it was 18 different medications, and came off and was protracted for many, many years. So so that would be another good resource, because a lot of this is about here, right? And undoing a lot of that fear and a lot of that work that you have to do to overcome a lot of these symptoms and these, I guess you can call them myths or something, like I'm bedridden, my brain doesn't function. Let's start talking, let's watch our self-talk and the things that we're saying about ourselves, because I bet you, if you really tried, you could get out of bed and get into a chair. I bet you could walk to the bathroom. I bet, you were able to type out this question. So your brain is working. Okay. So it's about reframing and watching what you're saying to yourself and what's the narrative you're telling yourself. That kind of work there is done with, in therapy, and done with coaches who understand what you're going through. So I mentioned a couple already. The Dave Powers is benzo focused, but Angela Peacock would be, benzo and other medications, psychotropic medications. She does individual and groups. So, and her groups are affordable. If you can't afford individual, you can get a lot from that. Also, to understand you're not alone. That's important. All right, I'm going to take one more question, and then we're going to be wrapping it up, okay? Because it's coming out past 2 hours here, and I'm starting to wind down. All right, Gina Ashman, this is the last question of the day. What are your thoughts about using lithium orotate OTC? Hey, I just talked about it. Can it be tried for bipolar 2 symptoms? If so, what dose, initial, and target, contraindications? So I talked about this earlier. This book here tells you everything you need to know. There's also Psychiatry Redefined has a webpage on lithium. I had asked Raul to put it in the comments before. I don't know if he was able to. Hopefully he was able to find that link and put it in the comments for you guys. But that's a great resource. So my thoughts off the top: lithium orotate can be used for bipolar 1 and 2. Okay. And people are surprised by that, but it can be. And as far as initially with, you have a bipolar 2 diagnosis, I would start higher. Oftentimes when you start lithium for other things, like maybe anxiety or memory, like I said, there's a plethora of things you can use it for. You're going to start low. 1, 2 milligrams, 3 milligrams. Starting off, and I know someone has bipolar, I know that they're going to need higher dose. So let's start at 5. And we do that twice a day. And then from there, we know go up. And then if you're not seeing benefits, usually this is another thing. It's not immediate benefits with lithium orotate. It does take some time because it's helping in the way as far as neuroplasticity, which takes time. So it helps with that. It helps reduce brain inflammation and it helps neuronal signaling. So it's going to actually help with all of the neurotransmitters. So dopamine, serotonin, GABA. It helps with all of those to help regulate all of those. So that's why it's very, very good for mood. Now, lithium carbonate, different, which is your pharmaceutical grade, lots of contraindications there. That you don't have to really worry about with lithium orotate unless you're going into high dosages. So, which would be if you're going to go above 30 milligrams total, then that's where you have to. So can do 5 milligrams twice a day, feel great. Some will need 10, some 20. Okay, when you get to 20, that's where I would say stop, max dose, right? And then kind of look at the possibility of having high lithium levels, even though even at that high dose of lithium orotate, it's still a very low risk. You can, at that point is when you can start seeing the serum concentrations. You will not have to do serum levels with levels below 40. Okay. So that's the major advantage of lithium orotate versus lithium carbonate, because lithium carbonate, much higher dosage, and also is seen in concentration in the blood, but needs to be monitored because you can become toxic and then it can affect the thyroid and the kidneys. So those things have to be monitored. When you get to 40 milligrams and above of lithium orotate, which most patients don't have to go higher than that, and I wouldn't recommend it, that's when you would want to start looking at those contraindications would be like making sure that your kidneys are functioning well, your thyroid is functioning well, and that your, as far as diet goes, stays relatively the same, that you don't end up with lithium toxicity, and looking and monitoring for those symptoms of lithium toxicity. Otherwise, before, if you're not going to push the limits on it, then relatively safe. And like I said, a lot of patients, especially with bipolar 2, your dose is going to be 5 to 10 milligrams twice a day, somewhere in between there. Okay, Gina? So that is it. Oh, we got a super chat. All right, so I'll answer the super chat and then that's it. All right, thank you for the super chat. Let's do our super chat because I did say those are priority. Celebration there. Let's take the super chat for the day. All right, and let's answer non-Vera's question. What does a full lab lookup include? Where do we start researching whys concerning labs lookup? So I have a video that goes over what I call the basic labs for mental health, but so we can link that down here for everyone to look at. But what I'll do is do like a brief overview of that and then some other things that I'm talking about. So labs to look at are going to be your basics. So your CBC, which is complete blood count, you're looking for that, like looking for anemias, any indications of inflammation in that, and then white, because that's also looking at white blood cells for infection and maybe even gut health and through the CBC. And that's why you do the diff, so you can get those differentials of your white blood cells to see if there's anything going on underneath, inflammation or infection wise, that could be a problem. CMP, which is your complete metabolic panel, and that one is looking at overall renal, which is your kidney function, looking at electrolytes, so sodium, potassium, calcium, phosphorus, or not phosphorus, sodium, potassium, and calcium. Phosphorus is a separate test. And then what was the other one? Oh yeah, CMP albumin. So looking at protein, total protein, which can signal to me that maybe you're not getting enough amino acids. Also anion gap, too high can mean like thiamine deficiency. So looking at the different clues that test will also show. So I said liver health, kidney health. So looking at that, then my thyroid test. So TSH, free T3, free T4, and then the TPO, which is thyroid peroxidase, and thyroid globulin antibodies. The reason why I check for all those and not just the TSH is because TSH by itself is useless. And oftentimes, because it's such a broad range lab, will look normal, but there's still some things going on underneath. So that's why you have to assess both the free T3 and free T4 as well to make sure that you're converting your thyroid hormones properly. And then also for the thyroid globulins, antibodies, and the TPO, I'm looking for Hashimoto's, because oftentimes that can go undetected for a long time, but can be a root cause of depression and anxiety. Then I look at inflammatory markers. So I categorize this under hemoglobin A1C, even though that looks like a diabetic marker. But the reason why I look at that, and then even fasting insulin if I'm really suspecting cortisol, is because those markers are more sensitive for an indication that we could be dealing with high cortisol than a fasting cortisol. And if I suspect it, then I would follow up with a diurnal cortisol, which is a better test to assess the cortisol pattern. So I do that, and that can also indicate like insulin resistance and things of that nature, which is oftentimes seen with inflammation. So that's why I put that under my category for like inflammation. And then homocysteine. Now, homocysteine is, if you haven't seen my MTHFR video, is like a byproduct is if you're not able to properly metabolize your folate, your B12, your B6, you can end up dumping more homocysteine, and that can be neurotoxic and inflammatory. Lots of studies on how it affects the brain, but also the heart as well. So oftentimes cardiologists will even look at homocysteine, but not realize that it's, in my opinion, more of a mental health marker because of its neurotoxic effects. So definitely check homocysteine. If it's someone I'm suspecting a lot of inflammation, then I'll go a little deeper and do like interleukin 6, do a SED rate, and kind of look a little more at other inflammatory markers. But basically speaking, homocysteine, and then C-reactive protein, and I'll do a high sensitivity C-reactive protein. So that one is also looking at general inflammation. And if I find these to be high, I start digging a little deeper. An ANA marker, which is to assess for autoimmune conditions. It's an ANA screen, and then you can reflex to the titers in Quest if you're ordering it through there. LabCorp may have it too, where it reflexes. What that means is if the ANA is high, it'll automatically then go and look to see if you have any titers for specific autoimmune conditions. Now, when you're looking at all of this, like I'm not treating those autoimmune conditions, but it helps me to say, okay, let's refer you to a rheumatologist who can help you with this, right? So that's like my inflammation kind of section that I'm looking at, autoimmune, little analyzer there. And then the nutrients. So iron, so looking at ferritin levels at least. If I'm suspecting more of that, I'll look at like a iron, total iron binding capacity and total iron along with ferritin. Of course, vitamin D, B12. I have separate videos on these explaining why, but very important. So vitamin D, B12, of course, B12 and folate can be done as one test where it looks at both of them. And then homocysteine, like I already mentioned, and the methylmalonic acid can also be done with homocysteine. It's a little more expensive for some patients if they don't have insurance, so I don't always include it, but will if I want to do a more sensitive test for their B12 if they have a deficiency or I'm suspecting one. And then what else? Oh yeah, magnesium. Okay, and so with magnesium, I look at magnesium RBC with magnesium serum together, and I talk about why in that magnesium video. And then that would be generally speaking. If I'm suspecting some other things, I may also do like zinc and copper. So that's like based off of your symptoms that you come to me with. So I try to make this all individualized. And then sometimes I'll do follow-up tests looking for those things. There's also another test called pyroluria, which I may look at if I'm suspecting, there's an issue with that, which could look like extreme mood disorder, irritability, and anxiety. Um, but back to basic labs. Okay, so I did my nutrient deficiencies, and then hormones. So basically, estrogen, testosterone, progesterone, and then DHEA. And DHEA is your adrenal gland hormone. So oftentimes when that's low, I can definitely tell we're dealing with some kind of adrenal thing. And I may want to go deeper. Like if I haven't done the diurnal cortisol, may recommend it at that time if I see it, to try to get a better idea of where that cortisol is spiking versus not. Um, and then I pretty much believe I caught it all off the top. I mean, that's where I would start. And then from there, it kind of gives you clues from there where to go. Now, I'm guessing because this is you used euros, so I'm guessing you're not in the US. Um, in the US, all the labs that I had just mentioned are typically covered. But as far as the uh, in your case, I don't know if they would be. So cost may be a factor there. So kind of ask. But I know in a lot of places in Europe, I believe you guys have like free healthcare or something where most of those tests should be covered. And it's all about making sure that your doctor understands the codes necessary to code if they have insurance. In the U.S. to code, and I don't know how it works in where you are, but something to consider. Um, and then I was gonna say something else before, because I see there's another question here. Um, there's something else I was gonna say about the labs. Oh, the other thing too is you don't have to go down that rabbit hole of the other tests that a lot of naturopathic providers will have you do right off the bat. They'll have you do an oats test and a food sensitivity test and all this like it can get wild, right? But doing the lab test at first, and then even someone who can be honed in on the symptoms, like when I see a patient, I can already tell, like, I'm going to want to see an oats test on this person because I believe that they have a lot of things going on metabolically, and even like maybe in their GI that they don't believe they do, but I believe they do. And having that oats test is going to show them that something else is going on underneath based off of the symptoms. That test also helps give like neurotransmitter information, like how the neurotransmitter, if you're depleted in those, but we're not talking like only central nervous system, we're talking whole body. So very lots of information there, but you don't have to go down those rabbit holes necessarily. You can get a lot of this information just from those blood tests that I just mentioned. And then from there, decide if we need to look a little deeper and look at all of these other tests. But oftentimes, just by looking at their blood test, you can see what someone is going through, what they're deficient in, and fix those things. Okay, so you're asking another question. I know you must leave, but how do I ask my doc to test these things in labs? I'm not sure how to ask for your mentioned labs or checkup. Well, that's the thing, and I'm glad that you had mentioned this because in your country, I think it's a little different. So I would say when you present it to him or her, maybe show them the video that I did on mental health labs. That could be a start to kind of get the conversation going. Like, hey, I saw this video on mental health labs. I'm really suffering with mental health symptoms XYZ. We have tried XYZ treatment. It hasn't worked. So I really want to see what's going on. Or I'd rather not try XYZ treatment. I'm against medication. I really want to take a more holistic approach. Can you help me in understanding what else can be going on? Okay. That gets the conversation started. You're not putting them in a position of like, you don't know what you're talking about. You're just saying, like, hey, I saw this and I have a question about it. Can you help me? Because either one, the medications that you're on, maybe they aren't working or you're reacting to those, or two, you rather not even go down that path because you don't want to become injured by the medications, right? So you're trying to do things more naturally. It's more in line with what you want to do. And so that's a way to kind of open up the conversation with them, and hopefully they have the time to give you, and to be receptive to that. If they're not, I don't know how easy it is to find a provider where you are that can do these tests. But looking for, a functional mental health provider or integrated mental health provider would be my next step if I were you. Now, Dr. Greenblatt in Psychiatry Redefined, which I mentioned his book on lithium here, but he's written a lot of books. This is his book on lithium. He's written a lot of other books on antidepressants, antidepressant withdrawal, depression, etc. Lots of information. But the reason I brought him up is because his website is another resource for a lot of information for providers. It's provider driven. I'm actually in his fellowship. I'm learning from him directly. So that could also be another way, like to kind of show him that website, and maybe he or she would be interested in where they end up, joining the fellowship, or at least learning from some of the free webinars, because they have hundreds of free webinars there for providers. And then also because he has a resources tab that has a list of providers. So it has a list of providers that are functional medicine. A lot of them are US based, but some of them aren't. Some of them are in Canada and the UK and other countries. So maybe there's someone there on that list that could work with you or help you. So just kind of trying to help, give you some resources if your provider is uncertain or unwilling, to help you in this regards. But to be straight up with you, I've worked with patients in a coaching manner outside of the country. Like I've worked with patients in Canada. I've worked with a patient in London. And so I've worked with patients, even one in India, like outside of, and what I help them is, to learn, educate about whatever their issue is, what their symptoms are, and try to identify what their needs are, but then also write up, a summary of what I see is going on, and then, kind of like a call to action for their provider. And then I believe I do it in a way that the providers are very receptive and understanding, and then they work with the patient, within putting in the plan. So sometimes the provider may be uncertain or unsure because they don't know what to do. So they may kind of back off because they don't know what these tests mean. But then what you can say is, well, so if you're going to work with someone like me or someone, that's not in your country per se, as a coach, I have someone that can guide me. Would you be open to that if we did these tests and I let her evaluate them and see them and kind of help educate us on next steps on what we can do? So as a team, work together in that capacity as a mental health coach, helping your provider and you kind of look at the big picture and see, what things could be going on underneath. So that's, what a coach can do. So whether it's me or other mental health coaches, that can also be another option for you. If you're, trying to get to your provider and allowing them to help you. So I wish you all the best. I know that was long, but I wanted to make sure that you understood all of that. And I really also wanted to make sure that you understood that I appreciate your super chat as well. So thank you all. That wraps up the live session. And hopefully you guys got a lot of information out of this. And if you want to keep in touch with me, levelheadedmind.com. You can sign up for the newsletter. It's at the footer there of my webpage. And hopefully we'll be in touch. You all take care. And I'll see you all in the next video. Next week, I'm doing the video on Ritalin, and then have a couple other videos lined up. Like I said, deprescribing video coming out as well, which it sounds like many of you are going to be interested in. And also, I forgot to mention to consider the membership. So we have a membership, and just consider that $4.99. And with that, you're supporting me to help keep making the information, because I take a lot of time to make these videos and to do all these things. But also you get priority answers to comments, chats and lives. And then we have special lives. My next member live is going to be next week. So my next members only live is next week, smaller group, so more one-on-one. So consider, replying or becoming a member. So that way you can get more one-on-one. And once I get 10 members, I'm going to be doing a live, we're going to be doing Zoom calls with my members. So it's going to be even more interaction. But again, my next live session like this for members only is going to be next week. So if you want to be a part of that, consider becoming a member. And I guess that wraps it up then. So that's the end of the live stream. For next month, for the next live, it's going to be, I think it's March the 23rd, I want to say. Yeah, March 23rd. Just had to double check my calendar. Next live. So for you guys, if you missed some of this, 11 a.m. Eastern. To 1 p.m. Obviously, we went a little bit later, and if I can go later, I will. But hopefully, you guys all got something out of this. Thank you so much, every one of you, for supporting this channel in one way or another. And I'll see you next time.